Good afternoon, everyone. Today we'll be discussing on ventilator waveforms. Previously, we tried to cover mechanical ventilators in general. So far, we have discussed about the modes, way of breath delivery, and how a patient can receive breath. So this is a follow-up on that regarding ventilator waveforms. So again, to introduce myself, my name is Dr. Biniam Bata. I'm a Assistant Professor in Emergency and Critical Care Medicine at St. Paul Hospital Medical College, Abit Hospital Addis Ababa, Ethiopia, which is an affiliate of St. Paul. So today's discussion will be on ventilator waveforms. So in this discussion, we will be covering, in general, these are my contents. So in this discussion, I will have introduction, the ventilator waveforms, what does colors mean, loops, how does a graph look like on SIMV mode, and ventilator desynchrony. So as an introduction, the purpose of this discussion is to know the routinely available ventilator waveforms so that we'll be able to detect any alteration in pulmonary physiology or lung mechanics. So to discuss the pathophysiology changes of the ventilator-supported patients while they are on mechanical ventilators. So after this discussion, our goals of this discussion would be to identify the pathophysiologic processes that will be recognized on the ventilator waveforms, recognize the change in patient condition, and optimizing the ventilator setting and treatment of this problems that arise or the problems that we will identify on waveforms, to detect the adverse effects of mechanical ventilators on the lung, and to minimize ventilator-induced complication. So we will achieve that by analyzing or monitoring the ventilator waveforms. So this is just a diagram showing what we will be able to diagnose or see on ventilator waveforms. The first one is abnormal lung mechanics. That could be auto-PEEP, or we could check the compliance of the lung, if there is airway resistance. And we could also check if there is any problem with the circuit. There could be secretion building up in the circuits, or whether the circuit has leaks. And the other one is patient ventilator interaction. That could be active inspiration or patient's effort, or is it controlled breath, is it assisted breath, or is it spontaneous breathing? We'll check it on the waveform. So by knowing the waveforms, we'll be able to answer the most crucial, important points that are here. So what are waveforms? Waveforms are the graphical descriptions of patient ventilator interactions. So they represent what is happening at the current time or state, how the lungs and the lung parenchyma is responding to the pressure or the volume that we are introducing to the lung. So waveforms are further classified as scalars and loops. So scalars imply it's a real-time display of volume and volume pressure and flow that are graphed against the time. So time being x-axis and volume, pressure, and flow will be presented on the y-axis. Loops are tracing of the volume plotted against pressure or flow against volume. So this will be represented as pressure will be present on the y-axis, and volume will be on the x-axis, and flow will be on the y-axis again, and volume will be on x-axis. So those are loops, and definition for scalars are those. So when we come to scalars, the first scalar scalar graph or I want to discuss is the pressure time scalar. So remember about our last discussion about peak airway pressure, plateau pressure, mean airway pressure, lung compliance, all are present in this pressure time scala. So the information we derived from the time scala depends on what mode or what are we trying to, what targeted breath are we giving. If you are giving volume targeted breath, usually has a peak configuration, so we'll be able to access pressure variables that I mentioned earlier. That could be peak inspiratory, plateau pressure, or airway pressure, and compliance could be assessed on the volume targeted breath. Because as our last discussion goes, the volume is what we set in volume target braces, but the pressure is variable. So we'll be able to assess those variability in the pressure that is created in the lungs. And pressure targeted braces, we target the pressure. So we deliver a certain pressure. So usually it has a square configuration. So it might not tell us a lot related with airway pressure dynamics. So this is the pressure time curve on volume targeted ventilation, which we briefly saw last time. So the y-axis is the pressure and the x-axis is the time. So we start here and we go clockwise. So initially there is initial peak of pressure. That is the pressure generated as the pressure that overcomes the airway or the tubes, the ventilator tubes, followed by a steep rise in pressure till it peaks at the peak inspiratory pressure. This steep rise implies the pressure used to overcome the circuits, the AT tube, and the larger airways, followed by a slight drop and plateauing, which we discussed last time as plateau pressure, or we can call it peak alveolar pressure. This is a plateauing phase, followed by exhalation. So as you can see, it's in x-axis the time. So the inspiratory time would be represented from this point till this point, and this after this point up to here will be presented as expiratory phase. Then it will continue in inspiratory phase later. So in volume targeted ventilation, we discussed briefly last time. So we will try to see what information we will see on the pressure time curve when we put it on volume targeted brace. So the initial picture shows a normal lung where there is a rise in pressure up to the peak inspiratory pressure, then a little drop in the transalveolar pressure, then followed by the plateau and followed by exhalation. So whenever we have airway resistance, the initial part or the initial elevation of the wave will be elevated and peaked. So peak inspiratory pressure will be high, but the transalveolar pressure it's also increased, but alveoli or the plateau pressure is not changed. So this implies there is an airway resistance. So this could be obstruction, or could be obstruction, or it could be obstructive lung disease, maybe asthma or bronchitis could be attributed to this. And the other graph, the third graph that is shown here, shows where both the peak inspiratory pressure and the plateau pressure or the alveoli pressure are both elevated, and there is more steep pressure elevation at the initial phase, followed by peaking of the peak plateau. So this implies when both are increased, so that means the larger the pressure needed to overcome the larger airways as well as the alveoli, when it's increased, it implies there is decreased compliance. So this is another way of checking compliance on pressure time curve. So the other thing we would see on the pressure time curve would be the IE ratio. That's inspiratory to expiratory ratio. So we usually calculate it from the relative lengths of the inspiration and expiration on the x-axis, which I briefly touched earlier. And peak airway pressure, it's the highest point on the pressure tracing measured of the y-axis. It's a y-axis. It implies the pressure needed to overcome all the airways, larger airways, the AT tube, and circuits. Plateau pressure is the shouldering and the pressure tracing that lies beyond and below the peak airway pressure. That we'll be able to see on a y-axis. So we'll be able to tell the peak inspiratory pressure, and we'd know the plateau pressure, and mean airway pressure will be also known. Mean airway pressure, as per our discussion last time, it implies all the area under the curve would be the mean airway pressure, including the PEEP or the area under the PEEP line. So this is what we'll probably see on a ventilator patient data waveforms. So on the flow, we have chosen the square waveforms. So you'll be able to see the peak inspiratory pressure and the plateau pressure. So the time around from here to here will be the inspiratory hold time in inspiratory hold time. So it will be represented on the graph here and followed by exhalation. So as you can see here, peak is also high and plateau is also high. So this could be a graph probably that you would see on when there is airway, increased airway resistance. So the peak inspiratory pressure is very high. And if you remember last time our discussion, the difference between peak inspiratory pressure and plateau pressure ideally should be 5 or less than that. And as you can see here, it's much more than that. So we might think there might be airway resistance. So we can also see the set PEEP estimated from the distance above the baseline where the inspiratory tracing begins or comes back. So this is a graph which shows the PEEP. So you'll be able to see the PEEP will be around here from 0 up to here, probably 5 centimeters of water. So the PEEP will be presented as this. So the pressure wave moves and the PEEP will be represented as this, be it on pressure control ventilation or volume control ventilation. The pressure time scalar will show as a PEEP, which is above the set baseline. The other thing we'll be able to see is auto PEEP. We usually say the PEEP. So auto PEEP is result of air trapping that's not removed during expiratory phase. So that will be, the air will be building up there. So the graph would not, during expiration, the graph will not go back to the PEEP level, rather it goes above. So this is the actual, the PEEP that we set, but as you can see on the graph during expiration does not come to the level of the PEEP. So this is what we will see the actual PEEP. So the difference between the actual PEEP and set PEEP would be the auto PEEP that is generated. So we have discussed on airway obstruction. As we said, both the peak in airway pressure will be relatively high than the pause pressure or the plateau pressure. So we'll be able to see that and we'll see the disproportionate rise, and we'll be able to tell that there is an airway obstruction. And we could also see response to the bronchodilator. For example, if you had an asthma patient on mechanical ventilator and he developed asthma attack, already on asthma attack, would give bronchodilators, and we'll see the response on this graph. So we would expect the peak airway pressure to come down near to the plateau pressure. So we'll be able to assess the bronchodilator response. So we use the pressure time scala or waveform. The other thing what we'll be able to see on pressure time scalar is if a patient has control or assisted breathing. So we said earlier, controlled breathing happens when the patient is not breathing by himself. So the inspiratory and expiratory phases will continue by the time we set, or the inspiratory time we set, and the expiratory time will be set according to the respiratory rate. So as you can see, there will be, whenever it's controlled ventilation, there will be rise in airway pressure and drop. But whenever we have assisted breath, there will be a negative deflection. So the patient is generating negative airway pressure, so there will be a negative deflection, followed by the mechanical ventilator taking over and delivering the set pressure to the patient. So the wave will be looking like this. So if you have a negative deflection on the wave, it implies it's an assisted, it's a patient has triggered, and as you can see, it has been assisted to the maximum or the pressure that we set. Okay, so far we've seen a pressure time scalar. So the next discussion will be on the flow time scalar. And most of the mechanical ventilators, we have 4 types of waveforms. So it depends on what ventilation are we giving. Is it pressure targeted or volume targeted? So in pressure targeted ventilation, because there is a consistent pressure within the inflating lung, so the pressure has to be maintained within the lungs. The flow waveform usually is decelerating or descending ramp flow waveform, which I'll show you, which I'll come on the next slide, what it looks like. But when we have a volume targeted ventilation, mostly this is a square waveform, because the volume will be delivered via the flow. So the pressure will be variable, but the flow is constant. So as long as the volume or the tidal volume is delivered, the flow is always constant. So it will look like more of a square flow form. So this is the waveforms that we'll be able to see on flow time scala. So as you can see, there is a constant flow square form that we usually see on volume targeted braces, and the decelerating reverse ramp flow waveform that we'll be able to see on the pressure targeted ventilation. So sometimes the VCV could be set as sine wave waveform ventilation, which is more or less physiological. So we could also use the sine wave, but the first two are for the volume targeted, especially the constant flow waveforms most mechanical ventilators use, and the decelerating reverse ramp flow is waveforms for the pressure targeted. So that leaves the accelerating ramp flow waveform. This waveform usually is found when we set patient on pressure support. Mind you, pressure support, not pressure targeted ventilation, but rather pressure support ventilation. They will have accelerating ramp flow waveform. This waveform could be seen also on SIMV modes if patient is not, when patient is getting the spontaneous brace with the pressure support, which I will come in the future. So what happens during the flow time scala? This is the events that take place during this flow time waveform. So the initial is A would be the beginning of inspiration, followed by the rapid rise to the peak, and followed by sustained pressure at a constant level until the tidal volume has been delivered. Then the end of inspiratory phase, so the graph will be dropping to 0, and followed by the end inspiratory pause, or the time that we set will be seen here, or the end inspiratory time that we set will be here, followed by the exhalation. So this point will be the peak expiratory flow, and this is the exponential decay of the expiratory flow during exhalation. So points to focus will be the peak expiratory flow, where does it lie, how is the decay of expiratory flow during exhalation, which we'll see what those imply. So the other thing I want to see, what we see here is the shaded area during inspiration, during the inspiratory phase, would be the tidal volume. This area will be the tidal volume, and this will be the expiratory tidal volume, and this will be inspiratory tidal volume. Ideally, they should be equal, which we'll see. Okay, what information can we get from flow time waveform or scala? If you are using the volume target brace, so we would know if we have a square waveform flow pattern, we will know that it is a volume targeted brace. And if it's decelerating flow pattern, we will know that the mode is pressure targeted brace. So we can also see the magnitude of inspiratory flow that could be measured on the y-axis, which in the inspiratory flow or the peak inspiratory flow. Also, the expiratory flow would be seen also on the y-axis, but on the negative side of the y-axis. So rise time could be visually estimated. So we'll see the rise time to achieve the tidal volume will be seen on the x-axis. So the other thing we'll be able to see is auto peep. On this graph, we will be able to see auto peep. So auto peep will be like failure of the expiratory flow tracing to return to the baseline will be designated as auto peep. So this is waveform from a mechanical ventilator that's showing the flow. As you can see here, this is expiratory phase. So inspiratory phase starts here and ends here, followed by a small end inspiratory pause, then followed by expiratory phase. As you can see, the expiratory phase is not coming to the baseline. So it's actually building up. So this is how we know that there is presence of auto peep. So as this waveform at this condition persists, the trapping will increase time after time. So the initial trapping was small, then almost doubled, tripled, even quadrupled here, and continues. So expiratory flow failing to return the baseline further causes air trapping. This air trapping also results in increased airway resistance. So increased airway resistance will be here, will be seen on the pressure curve as the peak airway pressure is consecutively increasing from the initial level and proceeding to increase. So air trapping results in increased airway pressure. So you'll be able to see the effects of auto PEEP also uh, on the pressure time curve also. What else could we see? We could also see airway obstruction whenever we have on the flow time scala, whenever we have any obstruction. So usually what happens is the expiratory flow tracing deeply curves and takes longer to return to the baseline. Remember the graph I showed you when there is there is a delay coming to the inspiratory phase. They will have a slow decay of the expiratory phase. But on this whenever we have airway obstruction, this decay will be more prolonged and it will take more deeply curved decay. So you will see that on expiratory flow. And also the peak expiratory flow is relatively low than the normal expiratory flow will be that we will expect. We also, so since we can know there is airway obstruction, we could also see the response on bronchodilator. So whenever we apply bronchodilators in patients with airway obstructive disease, such as asthma, there will be partial or complete reversal of the airway obstruction pattern. So they will have the peak expiratory flow will slowly come up and deeply curved tracing will be coming to the original position. So this is what an obstructive time scalar looks like in obstructive airway disease. As you can see, there was the peak expiratory flow is here, a bit lower than the obstructive airway, and the exponential decay of the expiratory phase is also affected. As you can see, the curve has gone deeper and is more extended or more stretched. So it implies there is airway obstruction. So whenever we apply bronchodilators, we expect the peak expiratory flow to go further down, and we expect the concavity to come a bit up. So we'll be coming nearing back to here. So that will tell us there is the response to our bronchodilators also. The other thing we'll be able to see is the air leak. So whenever we have air leak, there will be decreased expiratory flow. So the patients will have asynchrony. This happens because when we set the cycling from expiration to inspiration, it's set around 25%. So after the expiratory flow decreases comes to 25%, then that will start inspiration. So whenever we have a leak, it's more likely the patient will be able to reach this 25% easily, so it will cause cycling to inspiration. This causes irregularity and we might lead to asynchrony. The other thing we'll be able to see on flow time scalas, like if there is any secretions or water in the circuit or ET tube secretions, we'll see create disturbance throughout the flow, especially on the inspiratory flow. So as you can see here, it's on volume targeted ventilation, the flow. You have those disturbances. Those disturbances imply there is a secretion in the ET tube or in the circuit. So whenever we have such disturbances, we should check whether the patient needs suctioning or the circuit has a trapping of water secretion. So we need to clear that up. So I briefly touched it earlier when we saw the first flow time scala on the volume target ventilation. So we all know mathematically flow means tidal volume per set time or inspiratory time. So we can shuffle these things and you could get tidal volume being flow times inspiratory time. So the area under inspiration will be represented by the tidal volume. So, and what we gave should come out. Ideally, they are equal. Inspiratory tidal volume and expiratory tidal volume should be equal. So if there is any reason that decreases the expiratory area, that implies the expiratory tidal volume, implies there is a leak. So this is another way of knowing there is a leak. Okay, the third part of the scala, the last part and the last part of the scala would be volume time scala. So volume time scala differs what mode are we using or what target ventilation are we giving. If you're using the volume target ventilation, the volume rise is usually linear and expiratory phase falls exponentially. So during the volume target ventilation, if we set the inspiratory hold time, there will be an applied pause here, or there will be flattening on top of the graph. That implies the inspiratory hold time. This would be the inspiratory time in the inspiratory hold, followed by exhalation or expiration. So when we come to the pressure targeted ventilation, on the pressure targeted ventilation, the volume might be variable because, as we said, we can set the pressure, but we don't know what volume we're getting. So the graphs may have different heights depending whether the tidal volume is achieved or not. So the area under this, the peak would be the tidal volume, so will be represented on the y-axis, and this will be the time. So we will be able to know the inspiratory time and as well as the expiratory time. So in the inspiratory time will be half of it, and the expiratory time will be half of it. So what information can we derive from volume time scalar? I already say inspiratory, expiratory time. The other one is the tidal volume, which is indicated on the y-axis. And the other thing is auto peep. So whenever we have any trapping of air during expiration, the inspiration starts before the expiratory phase or the graph reaches the baseline. So usually this will be interrupted around here, so we will not reach the baseline. So there will be some lost tidal volume or the volume which is trapped. So it will also tell us if there is any leakage or trapping. So usually the volume that we deliver should be removed till the end. So if there is some lost, we'll be able to see it on the graph. This also could be air leak or auto peep. So this is what basically we see on the volume time scala. So far we have discussed on the pressure time scala, the flow time scala, and the volume time scala. We already said the pressure time scala is important, especially if you are using volume targeted ventilation. We'll be able to assess the peak inspiratory pressure, the plateau pressure, and the airway resistance, and as well as compliance. And we could also see the set peep and auto peep if they are present. And if you are using the flow time scala, we'll be again able to see if there is any auto peep, if the expiratory phase fails to reach the baseline, if there is any airway resistance. So the peak expiratory will be a bit lower, and exponential decay will be a bit curved during expiration. And we also said we can also see the air trapping, or if there is any air leak, and we can also see the bronchodilator response. Same thing on volume control ventilation. We say the inspiratory, expiratory time, the tidal volume, and the auto peep, or if there is any leak, will be visible on this graph. So this is about the scala. So the next part I would be discussing will be the loops. So as we said, loops are graphic representation that could be pressure volume loop or flow volume loop. So we'll be able to assess certain points based on visually inspecting the loop. So usually when we see the loops, there is inspiration and expiration. So if the pressure volume loop, it's patient is breathing assisted or controlled breath, the inspiratory phase is usually anti-clockwise. It goes up like this, followed by expiration. So which is better presented on the third graph. So this will be the inspiratory time, inspiration, the red line will be the inspiration, and the green line will be the expiration. So this is how it cycles anti-clockwise whenever the patient is getting assisted or control breath or mechanical breaths, or the machine is keeping the breath and the patient is not spontaneously breathing. So during spontaneous breathing, or when the patient is generating the negative pressure and breathing, as you can see, the inspiratory time, rather than being anti-clockwise, unlike the assisted or control, it will be clockwise. So there will be negative pressure generation. So the negative pressure will be present on the negative part of the x-axis, and it will be the inspiration. This will be the inspiration and followed by expiration. So usually the pressure is 0 because we have not set a PEEP in this graph, but if we had set the PEEP, the pressure will be around the set PEEP. So it will not be reaching 0 or baseline. Will not be reaching 0 or the baseline. See the difference, because we are using the assisted or control breath, which is technically a positive pressure ventilation. The pressure on the assisted or control braces will be on the positive side of the pressure, the x-axis or the pressure line. So what else could we see on the pressure volume scala? So we'll be able to see all the things we said that we'll be able to see on the pressure time curve in relation with the pressure volume in this loop, and the pressure volume loop. As you can see, this is the inspiration followed by expiration. So it's on the right side of the x-axis. So it implies that this is assisted or controlled breath. So this will be the airway opening pressure. So this is the airway opening pressure. So the peak of the inspiration will be the peak airway pressure, and this will be the delay that we said, or inspiratory hold time that we said, and then followed by the plateau pressure. This will be our plateau pressure, then followed by exhalation. So this area between the peak airway pressure and plateau pressure will be the transalveolar pressure, or it could be the airway resistance. So we will be able to assess airway resistance as well as transpulmonary pressure. So we'll be able to see this on the pressure volume scala. The other thing we will be able to see on pressure volume scala is whether the patient is triggering a breath and getting assisted, or it's controlled breath. So if it's controlled breath, as we said, there is positive deflection of the pressure to the pressure side during inspiration, followed by expiration, and comes to 0. But if the patient is initially triggering a negative pressure, which is again clockwise, a negative pressure, then the mechanical ventilator will take over and will deliver the set pressure, or the set what we have set, the pressure we have set, or the peak pressure will be delivered here. Or if it's volume, the pressure will be around to the peak inspiratory pressure will be achieved by the ventilator. So it will take, rather than clockwise during the spontaneous part, but it will be anti-clockwise and will create a loop behind the y-axis, or the negative deflection on the x-axis. So this implies the patient has triggered the breath and the ventilator has taken over and delivered the breath. So this will be controlled breathing and this will be assisted breathing. So how many what is the negative pressure that the patient has generated will be seen around here. So if you plot the x-axis here, this is the maximum negative pressure that the patient have generated. If a patient generates more negative pressure, this tail will be longer. So it will tell us the volume of the negative pressure that the patient is also generating. The other thing we'll be able to see on pressure volume scala is the PEEP. So the PEEP will be shaded, is represented on this shaded area. So the pressure will not be coming to 0, but rather than to the set PEEP. So this is a set PEEP and this is 0 PEEP. So the effect of applied PEEP on pressure volume loop is the plane of the tracing shifts to the right, and if it's 0 PEEP, it will be starting from 0. So the whole scala will be, the whole loop will be shifted to the right during when we set the PEEP. So that's the distance between this point to 0 will be the set PEEP. So the other thing we'll be able to assess with pressure volume scala, pressure volume loop is the compliance. Ideally, the compliance is represented on the graph as 45-degree line between the pressure and volume axis. So it will be represented as a blue line or B here. So this is the ideal line that we should have, a patient or a normal lung would have. So this implies the compliance. So if you see the green line, it takes more pressure to achieve the same tidal volume, or the tidal volume that we achieved is after generating higher pressure compared to the B when you look at C. So this implies this line implies the compliance. So the compliance is poor. So whenever we have any compliance which is poor, the loop would be more to the x-axis, inclined to the x-axis. So you'll see the inspiration coming from here, going like this, followed by expiration here. So we will compliance would be assessed by how the loop is oriented. Is this tilted to the right side or not? What if it's tilted to the left, or the loop is on the tracing of the A line or the red line on the graph? So that means to achieve a certain tidal volume, it took us small pressure compared to the rest. That means the lung is highly compliant or highly elastic, or this implies that the lung has lost some elasticity, or could mean the patient has emphysematous lung changes. So we would know by only assessing the orientation of the loop. So this is what the loop would look like. So as you can see here, the pressure 1 or P1 are represented here. The P1, for this P1 representation of pressure, we achieve a certain tidal volume. So for P2, it takes a larger pressure to achieve the same tidal volume. So the more of the graph is, or the loop is tilted to the right side, implying there is poor compliance, and P1 being a normal compliance if you are using the volume targeted ventilation. But if you are using the pressure targeted ventilation, again, the pressure will be for the preset airway pressure, because we are setting a certain pressure. So volume is variable again. So because using pressure targeted ventilation for the preset, for the pressure that we set, we achieve a certain tidal volume here. And for the same pressure on the blue shaded area, we achieve a certain tidal volume. So this implies that there is the compliance is poor. So this the first graph will represent a good compliant lung, and this one represents a poor compliant lung. So as you can see here, this is a wave again, a waveform representing the pressure volume scala. So we were also able to tell if there is any airway resistance. So what happens whenever there is resistance to the airway? So whenever we have resistance to the airway, as you can see, this being a normal graph, the pressure or the pressure axis or the x-axis, it takes a certain pressure to overcome the airway. As you can see, it's around here. So around 15 centimeter of water is what it took to overcome the airway. But as you can see on the graph on the right side, it's taking a larger pressure to overcome the airway. More the inspiratory rises stretched compared. It's not shooting up or it's not straight, but this one is a bit slanted. So it's taking large pressure to overcome the airway than to achieve the peak inspiratory pressure. This implies the pressure required to achieve to overcome the airways has increased, but the peak or the plateau did not change. So this implies there is some form of obstruction. So we'll be able to see if there is airway resistance on the pressure volume curve, as you can see on the graph on the right side. So this could be obstructive airway disease or ET tube obstruction. So we will be able to see or predict what is coming. So what happens when we have when we lose volume or wherever there is a leak or trapping? So this is the inspiratory, as we discussed again, the red line is the inspiratory phase. During inspiratory phase, a certain tidal volume was delivered. So we expect the same tidal volume to be going out, right? But the same tidal volume is not going out. It will come up to a certain point. So this distance between this distance between 0 to a certain tidal volume would be the lowest tidal volume, because we were expecting the expiratory tidal volume to be equal to the inspiratory tidal volume. So this will show that we have lost a certain volume. So this could be auto-peep or this could be leakage. So far, we have discussed how to check compliance on the pressure volume loop, and we were also able to see airway resistance, if there is any airway resistance in the pressure volume loop, which is so if whenever we have any resistance, the pressure rise will be more slanted and it takes higher pressure to overcome the airways than the peak or the plateau pressure. So we'll be able to assess that, and we will be also able to assess if there is any volume loss or if there is any trapping or auto peep. So the second part or the second part of the volume, the loop part is the flow volume loop. So usually flow is represented on the y-axis and volume is represented an x-axis. So we'll be able to see the flow rate on the y-axis and the tidal volume on the x-axis. Usually most ventilators will display the inspiratory curve above the x-axis and expiratory curve below the x-axis. So this is what I meant by that. Inspiratory flow is usually presented on most of the ventilators above the x-axis, and expiratory phase is represented below the x-axis. This is during volume control ventilation. As we said earlier, volume control ventilation could have flow curves, could be squared or sine wave, and we usually use the square waveform. So this is the sine wave flow pattern, and this is a square flow pattern during inspiration. So you remember our last discussion when we were talking about the flow rates when we're using volume control ventilation, or when we're delivering the volume, we said we don't actually control the time or inspiratory time, but rather we control the flow rate. So by controlling the flow rate, we'll determine the inspiratory time. So increase the flow rate, inspiratory time will be shortened and expiratory time will be prolonged. And if you flow rate is decreased, the inspiratory time will be prolonged, and the expiratory time will be shortened. So this is the flow rate. So the flow rate is increased depending on what we have set. So this shows different flow rate targets or different flow rates that we have set. So it will be shown here. So we will be able to tell what the flow rate or the flow rate currently, or what's the flow rate that we are seeing. Usually flow rate should be 14 to 60 liter per minute, as we discussed earlier or in the last discussion. So what else could we see on flow volume loop in pressure support ventilation? This is, I just said, volume control ventilation, and this is on pressure support ventilation. So whenever we set the pressure support ventilation, or PSV, not pressure targeted ventilation, the flow, usually we say like the cycling is dependent on the flow. So this is the peak expiratory flow. So 25% after the peak expiratory flow decays to 25%, the machine will cycle to inspiratory. So this will tell us what ventilator cycle is, or the cycling is. What we said, the cycling will be seen on the graph also. So what happens whenever there is increased airway resistance on flow volume loops? So the graph on the right shows the normal graph that we will have. During the inspiration, the flow will peak up to 100 on this graph and drops down, then expiration proceeds. Inspiration and followed by expiration. So whenever we have increased airway resistance, the initial inspiratory flow will be low, because we say the flow is restricted. There is some form of increase or restriction during inspiratory flow, followed by decreased tidal volume. Then it drops by, it loses its flow, then cycles back to expiration again. So the graph will be more of diminished, and rather than achieving the flow rate that we want to achieve, the graph will be diminished and small. So this it will tell us there is increased airway resistance both on the flow and on the volume. So this graph shows us whenever this graph will be there, whenever there is inspiratory flow restriction as well as expiratory flow restriction. So there is some form of obstruction on the ET tube or the ventilator conduction system. What happens when we have obstructive airway disease? So whenever we have obstructive airway disease, initially the flow will be high to achieve a certain tidal volume, and it will be a slight blunting at the corner will be there in the presence of increased inspiratory resistance. If there is no inspiratory increase, or there is normal flow, that graph would be somehow, will not be notched or curved at the top corner on top left corner. But as you can see here, there is no chink, and there is decreased peak expiratory flow. The peak expiratory flow expiration is also affected, and there will be concavity of the graph. So this will imply there is obstructive airway disease. So we should see this. What happens when we give bronchodilators, or the response that we'll be able to see, the peak expiratory flow will increase, and the shouldering or the scooping of the graph, the expiratory phase of the graph will be coming, or they will be straightening rather than scooping. So we'll be able to assess the bronchodilator response on the flow volume curve. We will be also able to assess the presence of auto PEEP or air trapping. So normally we expect the flow to be coming to a certain point or zero, because we don't, there will be zero flow, then it will cycle to inspiration. So as you can see here, the inspiration followed by expiration, but during expiration, the graph is not returning to zero, but rather the graph is coming to stop or to join the flow axis or the x or the y-axis prior to zero or the baseline or what we have started. So this area would imply there is a development of auto peep. Okay, how can we tell there is how also we can also see if there is any compliance issues or decreased compliance or reduced compliance. So whenever we have a reduced compliance, if we say the lungs are not expanding well for the pressure or the volume we are trying to push into the lungs, there will be stiffness. The lung will not be recoiling or will not be expanding. So whenever we remove, that's during inspiration, but during expiration, because the lung is stiff, the expiratory phase will be very fast or rapid because the lung is stiff, so it will suddenly collapse after the pressure or the volume that we want to achieve is delivered after the inspiratory time. When we go to the expiratory time, the lung will be pushing down or it will be stiff, so it will be compressing. So there will be rapid flow of air. So this will be represented on the flow volume loop as the increased expiratory flow. So this is the inspiratory flow followed by high expiratory flow. Also, there will not be sharp end, but rather than scooping on the expiratory part of the end expiratory, peak end expiratory flow. They will be scooping rather than being sharp. So this is a graph also, this is a graph for the flow volume loop. This shows volume loss. So this is, as we said, there is inspiration and followed by expiration. So we say the tidal volume should be equal during inspiratory time and expiratory phase. Inspiratory phase and expiratory phase of should have equal tidal volume ideally, or they should be equal. So this is during inspiration. On expiration, the graph is not returning to zero, or it's not the same tidal volume that is going out. So there is a volume loss, or the graph will be joining the x-axis prior to zero or before reaching zero. So this will imply there is a volume loss. So you'll be able to see if there is any leakage. So probably this could be leakage or fistula, or if there is any ETT cuff leak. So in general, there is only be leakage. So the inhaled volume will not be returning to the expiratory sensor, or the inhaled volume and expiratory volume has a difference. So whenever they have a difference, we'll consider volume loss. So this is a graph on SIMV mode. So as you can see, this is volume targeted ventilation. Why do I say that? Because in volume targeted ventilation, we say the volume is a square pattern because it's a sharp rise and followed by dropping, and the flow is also square pattern here. So we'll be able to tell it's the volume control ventilation. And as you can see here, there is a negative pressure generation at the pressure time scala on the volume targeted ventilation. So this implies the patient has generated a negative pressure, a certain negative pressure, followed by assisted brace, or followed by the volume assist that the patient received to achieve a certain pressure, then it will drop. Followed by there is a negative generation, negative pressure generation, but it's not assisted, but rather it's not a pressure volume assisted, but rather it's pressure supported. So a certain pressure support level is given to the patient, so the inspiratory time will take, then followed by expiratory, as you can see here, and the flow will be also similar like this. This is SIMV plus pressure support mode. So what happens when we say SIMV or SIMV volume, SIMV VCV mode, but we put the pressure support to be 0 or we're not giving any pressure support. So if you're not applying any pressure support, again, the patient initiates or triggers negative pressures, and it's the assisted volume is delivered. Again, the patient initiate another negative pressure, but it's not pressure supported, but certain tidal volume is delivered to the patient because the patient is able to generate certain negative pressure. Certain tidal volume will be generated. Again, the patient also again tried to trigger the machine, but it did not receive any pressure support. It only got a certain tidal volume. And time after that time lapse, on the third time when a patient started to initiate a negative pressure, the mechanical ventilator took and gave a certain volume to achieve a certain pressure. So the set tidal volume was given after this trigger. So that's how we know that the patient is triggering, or the pressure support that we set will be seen as SIMV mode like this. Otherwise, if there was control breathing, if the patient did not initiate the negative pressure, this will not be recorded. So the inspiratory, once the inspiratory time is reached, the tidal volume will be delivered. So you'll only see the pressure only on the positive axis of the pressure curve, not on the negative side. So you will know whether it's controlled or assisted. So those both braces are here are assisted brace by volume target, volume assisted, but the rest are not assisted. And on this one, this is pressure assisted because the patient, as you can see, the patient initiated the negative press and there was a pressure support. Pressure support was given to certain pressure, then started expiration. So the other part or the other topic I would like to discuss after seeing the waveforms, ventilator desynchrony. I will come the reason we may have why we may develop ventilator desynchrony, but let's just go through what we will see on the graphs. So usually ventilator desynchrony occur due to inaccurate sensing of patient's effort. That could be what we have said. Usually sensors or the modern ventilator sends the patient effort in two ways, either by detecting the decrease in airway pressure or the generation of negative pressure, or flow between an inspiratory and expiratory circuit. So if we said to start inspiration, after patient generates negative 2 centimeter of water, then inspiration will start after generation of negative pressure, then inspiration will proceed due to till that inspiratory time ends, then expiratory phase will proceed. And the next cycling would be after the flow delivered during inspiration comes out as expiratory, as expiration. When it comes to the level, or when it comes to a certain level, or 25% of is left, the difference between the inspiratory and expiratory flow reaches 25%, the machine will cycle back to inspiration. So basically, we will set the sense to be pressure or flow. So whenever we set inadequate sensing, or whenever we set those negative pressure or flow settings for the trigger, if we did not set the adequate one, it will lead to patient asynchrony, because the patient will be going between inspiration and expiration frequently. This will cause tachypnea or increase work of breathing, and it will lead to ventilator desynchrony and patient discomfort. So as you can see here on this graph, on this ventilator setup and ventilator graph, this is a VCV mode. This is the flow and this is the pressure. So usually flow will cycle to the expiratory phase. The expiratory phase will cycle to inspiration after a certain flow is achieved or a certain pressure is generated. As you can see here, there is a patient effort to generate or to trigger the ventilator during expiratory phase, but it's not picked up. So it will continue. And again, this will happen again. So it's not picked up and it's not missed. So this causes fatigue and desynchrony, and it will cause development of autopy, because the expiratory phase was interrupted by the patient effort, and it will cause building up or trapping of air. So we'll be able, if there is wave changes and the flow on the flow expiratory phase, we should this imply there is patient effort. And this will tell these things, if left untreated, they will lead to development of autopip, because there will be continuous cycling of patient from expiratory to inspiratory before the whole expiratory volume is removed. So there will be trapping. So in order for this not to happen, we need to adjust the trigger. Usually this trigger is set on pressure. So the patient is trying to generate negative pressure here. So the trigger we have set might be high. So the machine is not sensing it. So you may have to adjust the trigger in this case. So if you trigger the trigger threshold to come up higher, the machine will sense this and will deliver a center press. So always don't forget to check the triggers. So this also could happen if there is air leak. So if there is air leak and we set the flow to be the trigger, there will be loss of PEEP, there will be loss of volume, then there will be loss of flow. So whenever there is a loss of flow, the ventilator will interpret as triggering, so it will cycle back to inspiration. This will cause also a desynchrony. So we will need always to check if there is any desynchrony. Whenever we have desynchrony, don't forget to check if there is any leak or not. So this is, as you can see here, there are high peak airway pressure on double inspiratory volume. So this is because the patient started inspiratory effort at the end of the inspiratory wave. So the wave went up during inspiration, and expiratory phase was about to start here. There was the inspiratory whole time, but the patient triggered the pressure triggered a certain pressure here, or it triggered the negative pressure here. So this causes certain pressure to be given or tidal volume to be delivered. So the pressure rose. As you can see here, the patient who had 2 inspiration consecutively without expiration. This happens when we set the pressure sensitivity. If we make it small, so the sensitivity become, for example, ideally should be 2 centimeters of water. So if you make it 1, so a slight movement in pressure will be detected as patient effort. So the machine will deliver the brace. So this causes, again, this will cause desynchrony. So it will cause air trapping, auto PEEP. So in this case, I will consider why does the patient initiated or triggered inspiration after the end of inspiration. One could be we were not giving the patient was not getting enough tidal volumes that the patient triggered to breathe, or there is patient desynchrony. The patient is trying to fight with the machine. So we need to decide which one is this. So probably we would adjust the tidal volume based on the ideal body weight. Is he getting tidal volume? If he is getting the adequate tidal volume, maybe the patient needs sedation, or do we need to change the mode from VCV to PCV or PSV? Or the last will be to paralyze the patient to prevent double inspiratory volume being delivered. So in general, summary of the patient ventilator asynchrony could be tidal volume too low from the ideal calculated or the ideal or predicted body weight, or the inspiratory flow is too slow. So if we make the inspiratory flow too slow, then the inspiratory time will lapse before the ideal volume is delivered. So the machine will cycle to expiratory phase. So we need to check the inspiratory time. And if we make the inspiratory time too long also, the patient might trigger inspiration before the whole expiratory volume is delivered. So we need to check the inspiratory time and the inspiratory flow whenever we have asynchrony. And we also have to check the trigger sensitivity. So if we make it too negative, the patient triggers to have a brace, but it will not be given a tidal volume, or it will not given patient will not receive the brace. So again, it will trigger, it will not be sensed by the machine, and they will, in time, the patient and the machine will start to fight. We will have desynchrony. So we need to take the trigger. If we make the trigger very high, the patient will be starting inspiration before expiration, because we expect inspiration to come followed by expiration. But if you make the sensitivity more higher or more positive, then the machine will think the patient, for every slight pressure change, the machine will give brace, despite being the patient being on inspiratory or in the inspiratory time, before expiratory time. So it will have the double volume will be delivered to the patient, and the patient may develop auto PEEP or air trapping or barotrauma or lung injury. So we need to also assess the trigger sensitivity. The other one we need to think is, whenever we have patient ventilator desynchrony, if there is any increase in the patient tube or respiratory circuit, so we should check the loops or the scalars, and we should check the alarm setting. So what is the pressure limits or the maximum pressure that we can tolerate? We should also check that to see whether patient, whenever a patient develops ventilator asynchrony. The other one is auto PEEP. So whenever there is auto PEEP, there will be trapping of air. So the trapping air will continue with every brace. So there will be accumulation of air. So the airway pressure will be high. So the adequate tidal volume will not be delivered with during a certain time. So this will cause more trapping again and more desynchrony. So we should also check for auto PEEP whenever we have desynchrony. And we should change patient's lung mechanics. So if you are using VCV and getting asynchrony, we will check all these things. Still no change, maybe we need to change the mode. The other option is patient should be sedated. If the patient has pain, discomfort, or agitation, it will cause desynchrony between the patient and the ventilator. So we should also check presence of pain, discomfort, or agitation in this patient. So maybe we may need to give neuromuscular blocking agents or sedating, or analgesia should be given. So by far, this is my discussion on ventilator graphics or waveforms. If you have any question, we'll be receiving now. So if you have any question, please forward them. And this was my references. So understanding mechanical ventilator second edition and ventilator graphics and respiratory mechanics in the patient with respiratory lung disease from the Respiratory Care Journal on February 2005, volume 15, number 2. I'm not seeing any questions from the comments. So probably We had a question last time, how would we differentiate a development of airway obstruction from ARDS, or patient was intubated for ARDS? So basically, we follow the loops in the scala. It was a good question. Could not answer it last time because it would be difficult to answer that question without me discussing how we would check the loops and scala and what information we get from them. So that answers by itself. So you will see if there is airway ARDS, we expect the compliance to be affected, not the airway resistance. So we'll able to see the compliance affected on the pressure time curve, or it could be the pressure volume scala on the volume mode, on the volume targeted mode. And if it is airway resistance, both the peak and inspiratory pressure and the plateau pressure will be affected, and we'll be able to see that on the pressure time scala on the volume targeted ventilation, or the pressure volume loop on the volume targeted ventilation. So we'll be able to know whether it is compliance which is affected or is this the airway resistance. So last week question basically answered easily with the knowledge of mechanical ventilators. So I'm not seeing any questions so far. So far, no question forwarded on the chats or on the YouTube live streaming sites. And so if you have no questions, on this discussion, thank you for your time. I'll be stopping my streaming here.